Um, I really appreciate that so many of you joining me at this hour of the day to talk about breastfeeding. That is quite amazing. This time I have a conflict of interest disclosure because apart from being a neonatal specialist, I'm also an international board-certified lactation consultant. And naturally, I believe that human milk is the most appropriate food for a human infant. But this talk is not about why people should choose to breastfeed or whether people should choose to breastfeed. This talk is about supporting a woman who is exclusively or is trying to exclusively or partially breastfeed her baby. Because breastfeeding, especially trying to exclusively breastfeed, is a really, really hard and often very long journey for women. But you know, so is raising kids in general, and you know, it's all really, really hard. So this is not to diminish any families or women who choose not to breastfeed their children. The thing is, it is the decision of a woman how she wants to feed her baby. But if a woman has decided that she would like to breastfeed her baby, her newborn, her infant, then we should do all we can during every situation possible to support her in that decision. And today I want to talk about what you can do if a woman is encountering an emergency situation, whether this be, you know, you attend as a paramedic in an accident, or whether she's coming into ED or the hospital with some emergency or needing surgery. So the objectives today, I'll tell you a tiny little bit about basic information about breast milk and lactation, because that's kind of a bit important to know what is going on at different stages to understand how important it is or what support might need to look like. Then how to manage the breastfeeding patient either on the way or in the emergency department in a holistic, compassionate and supportive way. Prescribing medications and ordering diagnostic imaging safely in a breastfeeding patient, and breastfeeding support when surgery or anesthesia or hospital admissions are required. So breast milk is a very, very amazing liquid. Call it liquid gold or whatever you sort of fancy. It is a liquid produced by the body which really has everything the baby needs, from the macronutrients, you know, protein, fats, and carbohydrates, to lots of other components. There is factors enhancing the development of the gut and of the brain of the baby. There are digestive enzymes in the milk to help actually digesting all the macronutrients, and there are protective factors in the milk like immune modulating factors. There's more and more components found in breast milk. At the moment, we're standing on well above 300 different components in breast milk. Breast milk has been shown, and there's good scientific evidence, to prevent illnesses in a baby and in a person who's been breastfeeding, and there is a dose-effect relationship. So the more breast milk, the longer a baby's been breastfed, the more those effects take place. That's shown for infections like acute otitis media, gastroenteritis, respiratory tract infection, for things like atopic dermatitis and asthma, so sort of immune modulated illnesses, but also things like obesity and diabetes, childhood leukemia, SIDS, and as well as necrotizing enterocolitis in a preterm infant. There are also illness prevention for the mother. Just the fact of her lactating, helps to reduce the number of type 2 diabetes, helps to prevent breast and ovarian cancer, and has a big role in preventing or alleviating postpartum depression. So breast milk not only has like all these wonderful components, but it also changes over time. As you know, initially after birth, colostrum is available. Colostrum is made very early in pregnancy, so it's actually there for the last few weeks, even months of the pregnancy. It's very scant and thick, but really has everything a newborn baby needs for those first couple of days until the mature milk is being made. And often you don't see much. So if the baby latches, it gets out the colostrum, but it's very hard to do that with a hand or with a pump. It's almost impossible. So even if you don't see much of that milk, there is that milk. So this is really important because the breast doesn't feel full. The breast doesn't kind of look like a lactating breast yet. But don't underestimate the importance of that colostrum. Very, very high for secretory IgA and really helpful in preventing illnesses for this baby, especially when the mom has gone through a infectious illness. The baby will get lots of preventative antibodies through the milk, as well as vaccinations. So very, very important. The production of the mature milk starts around 30 to 70 hours after birth, but can be as late as 96 hours, and if there's complication pregnancy, sometimes even later. We call that the milk comes in. The mature milk production is happening because of the hormone changes which occur with the birth. So you have initially during pregnancy the very high progesterone levels and prolactin levels, but with the delivery of the placenta, the progesterone drops and the prolactin level remains high, and that really elicites the hormonal effect for making the mature milk. But what's really important as well is the frequent suckling on the breast. So with a baby latching early and latching frequently, this is helping and necessary for the mature milk to come in. There is a period of about 2 weeks until a full autocrine system is developing, where there is a independent feedback loop just by the baby feeding and emptying the breast, where the removed milk will be replaced by the body. So if you want a demand and supply chain, the baby places the order, and then the breast, the body kind of reacts to that and makes the milk. So the more suckling, the more milk. Empty breast will make more milk faster. Full breasts will prevent milk from being made. There is a reflex called the prolactin reflex, which is really important for the milk production. And the prolactin reflex really occurs with nipple stimulation. Obviously, the best nipple stimulation at that time is the baby direct suckling at the breast. More suckling triggers more prolactin release. The higher the prolactin levels, the more milk production increases. And on the other hand, if milk is not removed frequently and effectively, then a feedback mechanism kicks in and slows down and eventually stops milk production. And then there is the milk ejection reflex, the milk which is sitting in the breast being released for the baby. That is regulated by oxytocin. And this is just a picture in case you ever wondered what love looks like. So, oxytocin, the love hormone, really, really important for breastfeeding. Now, the milk ejection reflex is something really important to remember when you look after a woman in a very stressful emergency situation. What needs to happen for that is she needs to feel all this love for her baby. Baby sits on the breast, she looks at the baby and sees the baby, she smells the baby, she hears the baby, and she develops this confidence with the baby being happy, feeding at the breast, latching well. Now, then there is lots of oxytocin, and the milk actually starts flowing. Sometimes women report they hear their baby waking up and starting to cry, and their milk starts going. And that is regulated by the oxytocin. So on the contrary, if a woman is stressed, if a woman is in pain, if she has a lot of doubt about that she's doing the right thing because, I don't know, the baby is really unsettled or the baby is not there, all these things reduce the oxytocin and the milk ejection reflex doesn't work. The milk stays in the breast, and sometimes that happens even if the baby is there and wants to suck. So you can imagine the challenges a woman encounters when in an emergency situation are very closely related to the natural process of breastfeeding. Discomfort and stress, depending on why a woman is in that emergency situation, generally it is associated with some pain or other. That's really, really unhelpful for milk making and milk ejecting. In general, the chaotic nature of an emergency situation or of an emergency department or an ambulance can make it really difficult to relax. And really relaxing is what she needs to have a good milk ejection reflex. There are privacy concerns. Women trying to find a private space to nurse find that often very challenging in those emergency situations. There's also different diverse cultural backgrounds where for some women it might be really easy and for some it might be incredibly difficult to pack out her boobs to breastfeed her baby. So this is very important to acknowledge because there is women who don't breastfeed just purely because of being in a populated space. Misinformation, and misinformation is what we're trying maybe to tackle here today. Some medical staff advise against breastfeeding when prescribing some medications or other, just to be safe, right? And say, oh, well, can't be bothered to look up, or I don't know, actually, this might be not so good for your baby, just pump and dump. That is really unhelpful. And then lack of support, just because often people who do not work with pregnant or lactating women very often are a bit conscious about their lack of knowledge, but then don't know really what to do and how to guide a woman through this situation. So what can you do, even not being a lactation specialist, to support your breastfeeding patient? The most important thing for this is actually to know that she's breastfeeding. So make it a just common standard sentence. Any woman you would ask, are you pregnant? You should also ask, are you breastfeeding? That is really, really important. And then recognize the need to empty the breast whilst in this emergency situation or in the hospital. And that's really important because, as you remember, if the breast stays full, there is less milk being made. And even if this only happens for 1 or 2 feeds, this can have a detrimental effect on breastfeeding success in the future. So the best way to empty the breast is actually for the child to be on the breast and feed. Because this is where you have all the right hormones there, and where you have the best emptying of the breast. It is possible often to organize a screen, or a private room might be a bit difficult, but a screen is often available to help with privacy concerns. And there's often this, babies don't belong in the emergency department, but you'd look after babies if they come for their own emergency, right? Babies are generally born in hospitals, so this is not quite true. A baby can be in an emergency department if it's important for the woman to continue breastfeeding. If it's really not possible to have the baby or the child there, provide an opportunity for her to pump or express. So the big step there, find a pump. All the hospitals who have some form of maternity care, delivery suite like a birth unit or a maternity or special care unit, they will have breast pumps. So organize a breast pump so that she can pump if her baby is not there to breastfeed directly. And then the next step is to find actually somewhere for the milk to stay, because whilst the milk can be in room temperature for a while, this is not ideal. And ideally, the milk is being stored in the fridge until it can be used. So find a fridge for her to store the milk. And reassure her that breastfeeding is safe. So when we talk about safety, it's to know that the vast majority of medications are actually safe for breastfeeding women. There is only very, very few medications where breastfeeding is really contraindicated. So they are the exception than the rule. Remember, the breast is not a placenta. So the medication safety profile in pregnancy and in lactation are completely different. And why is that? Because what you're looking at is the relative infant dose. So how much of this medication does the infant get? And that actually depends on a lot of different variables. So a medication molecule size, there are certain size molecules which do not cross into the breast milk, like heparin. It's dependent on how lipophil or hydrophil a medication is. The more lipophil, the better it goes into the breast milk. If it is a very hydrophil medication, very little goes into the breast milk. It also depends on whether the medication is bound. If the medication is protein bound, very little or nothing may go over into the breast milk. And then, when it's in the breast milk, it still depends on what the oral bioavailability is of that medication, because it doesn't go directly in the blood of the baby, it goes into the stomach. And if the medication has a very, very low bioavailability, then very little of this is going into the baby. So all these things are really important to consider when you prescribe a medication. But you don't need to obviously know that for all of the medication. What you need to know is that there are so many variables which affect on how safe or maybe not safe a medication is. And there is, sorry, this is a bit small, there is lots of different references you can use and you can easily use to check that out very quickly. So some of those references are available for free. Some of those references are you have to pay for. And it's often possible to get those references either onto a computer in your work environment or have a book, depending on, I'm sort of old-fashioned, I like books, but everything is available either online or as a paper copy. My recommendation, I love the reference from the mother's medications and mother's milk. This is a breastfeeding or lactation reference book which tells you specifically for each medication what the relative infant dose is and why, and also lists the research and the evidence, if there has been ever research done for those medications, and if there's been tests done, like blood tests on the infant. I think it's a very, very good balanced book because it includes very good recommendations for medication where we would think it might not be safe because we don't know whether or not it is possible to continue breastfeeding. So the conservative recommendation that a woman pump and dump, so express and then discard her milk for a medication or a diagnostic study, which we kind of do because we want to protect the baby for any potential sort of side effects, has a potential for harm. Because even if breastfeeding is only briefly interrupted, it can lead to early weaning. Also, if we say the woman says she's adamant she doesn't want to stop breastfeeding, no matter what you give me, what you prescribe me, I will not stop breastfeeding my baby. Sometimes medications which are really necessary are being withheld. And whether this is analgesia or whether this is antidepressant, that can be really harmful because it may lead to a significant reduction in oxytocin surge, and the withholding of the medication might actually affect the breastfeeding negatively. Prescribing medications that are not directly harmful to the infant can also lead to early weaning if they cause a decrease in the milk production directly. So these things are really important to consider when prescribing medication. So look it up and don't recommend to pump and dump. There are a few, it's a great table actually, which when you can see the reference down at the bottom, you can look up in that paper. Where you can see that there is only very few medications you would generally frequently use in emergency medicine, which should be avoided. Lots of medication where you may kind of have worried about are actually safe or generally safe to continue or to be prescribed whilst a woman is breastfeeding. So I'm not going to go through that list, but have a look at it because I think it is quite eye-opening because some of those medications you would have thought maybe not being safe for the infant. Diagnostic imaging. That's an interesting one because people get really, really worried when contrast is given. That's even if you go and have imaging with contrast, you sign pretty much your life away. You can have an anaphylactic shock and die. So there is kind of this anxiety about giving contrast to patients. And especially if a woman is breastfeeding, you kind of, oh, no, you can't, you can't possibly continue the breastfeeding. Now, I'll tell you, most common imaging modalities with the contrast associated are very safe for breastfeeding infants. So if you look at, for instance, the contrast you administer for X-rays or CT scans, which is generally an iodinated contrast, there is very, very low levels of that contrast going into the milk in general. And the oral bioavailability is actually quite low. So the infant dose for the contrast level is generally about 0.01% of that in the maternal system. For MRI, if you use gadolinium with an MRI scan, the infant dose is even lower. It's like about 0.0004%. It's sort of homeopathic. So very, very safe to do any CT, X-ray, or MRI scans with a woman who's breastfeeding. Not whilst she's breastfeeding, but you know what I mean. If you look at this, most of these contrasts, they kind of go straight over my head. I haven't heard them ever before, but I'm sure you know most of them and use them. So you can see behind them there is an L1, L2, L3. This is the scale which is looking at is there a possibility for harm for the breastfeeding infant. And you can see that from L1 to L5, L1 safest and L5 being contraindicated, all of the contrast agents which I have listed here on that side are actually either really, really safe or moderately safe for the breastfeeding infant. So none of these agents are, should lead you to recommend interruption of breastfeeding. So if I say that most common imaging modalities do not require an interruption of breastfeeding, well, some may. And when we talk about what is potentially critical, then it is anything associated with isotopes, and that is nuclear imaging. But obviously, with isotopes, it depends on the half-life. If an interruption is required. And then the advice may be to pump and hold rather than pump and dump. You just need to sort of store the milk long enough and the isotope will disappear. So there are it really depends on what isotope you're using. So if, for instance, you have a hepatobiliary immunodiacetic scan, gosh, I can't even say that, the half-life of that contrast isotope is so low that you don't need to interrupt breastfeeding at all. But this can go like, can increase. If you have a nuclear imaging using thallium, you may recommend a 96-hour interruption of breastfeeding. And depending on the urgency of those nuclear imaging scans, this is something you can work through with the woman. So maybe there is some time where she can pump more frequently, additional to breastfeeding your baby prior to the scan, so that she can then use her own breast milk whilst the other breast milk she cannot use at that 96-hour time is being stored in the freezer. Very important though, delaying a procedure for fear of hurting their infant, especially in the case where the research indicates that the procedure and contrast agents pose almost no risk, could cause long-term issues for the breastfeeding parent if a diagnosis is missed. So really think about it very, very carefully. A woman telling you that she is not going to interrupt her breastfeeding doesn't tell you, I don't want the procedure to be done. So really discuss with her well. Talk to her about pros and cons of maybe interrupting the breastfeeding if it is necessary, but leave it to be her choice and don't underdiagnose her because of her choices. So surgery and anesthesia. So if you encounter a woman who's, broken her arm, she might need surgery. As it so is with most emergency departments and hospitals and theaters, often there's quite a delay before you get someone to the surgery, especially if it's not like a life-saving emergency, right? So I don't know whether that happens in your hospital, but I think certainly in ours that people sit many hours, sometimes a day, sometimes two, to wait for the surgery to fix their limb or whatever has happened. So please try to facilitate for the infant to stay with the mother or stay as close as possible to the mother before the surgery and directly after. If that is not possible, try to provide the family of the woman a space where they can stay with the infant and bring the infant to her every 3 hours or so for the breastfeeding. Following an anesthetic, mothers of healthy infants can resume breastfeeding as soon as they are awake, stable and alert. The commonly used induction agents like propofol, thiopental have very, very short plasma phases, and therefore transfer to the milk is very low and sort of almost no transfer there. Anesthetic gases are very unlikely to transfer into the milk. And most analgesics are very compatible with breastfeeding. For example, like morphine, very limited transport into the breast milk itself, and then the oral availability for the infant is quite poor. Remember, women deliver their babies in sort of very different ways, but about a third are requiring cesarean sections to deliver their baby. When a woman has a cesarean section, we recognize the need for her to be with her baby very, very soon after the surgery is finished, in particular to support bonding, to support skin-to-skin time, and to support breastfeeding. So I cannot see why this is possible at the time of her delivering, and 2 weeks later, because she's come to the emergency department to get a broken arm fixed, it's not possible anymore. Try to advocate for your patient and reason with the theater staff, with the nurses, with the midwifery staff to look after this woman in recovery just as what they would with a woman who's just delivered a baby with a cesarean section. In Australian states and territories are plenty full of legislative provisions protecting the rights of breastfeeding women. And in most states, there are policies to support women to continue breastfeeding when they or their infant are admitted or present to inpatient, emergency, outpatients, or pediatric services. So please go back, have a look at what's available in your state, and use this policy to advocate for your patient to be able to stay with her baby and continue to breastfeed. If she has to be admitted or if she is waiting around in some ward or other for her emergency surgery, support her to continue breastfeeding. This could be just trying to admit her to the maternity ward rather than the general ward, because the maternity ward is very well equipped to support women with breastfeeding. And if the surgeons feel they can't walk to the maternity ward because this is not where they see patients, question them about their fitness level. Empower your patient to ask questions and to also question well-intentioned but excessively cautious advice. And if she really can't stay with her baby, organize a breast pump for her. Now, the breast pump is an interesting thing because it helps to obviously empty the breasts, and it helps with the stimulation, sort of similar to suckling. So the prolactin reflex is really helped by. It's not as good, though, for the oxytocin surge. You know, the love is just not the same if you have like a plastic pump hanging off your breast rather than your baby infant. But it is possible to maintain milk supply when a mother really has to be separated from her infant. To maintain the normal milk supply, the woman must pump very, very similar frequency as to what the infant would feed at the breast. So if the infant feeds every 2 to 3 hours, she needs to pump every 2 to 3 hours to maintain the same milk supply. This is really important because this has to happen 24 hours. So overnight, at home, the baby would wake up every 3 hours to go onto the breast. Well, she would need to continue with that pumping if she's separated from her infant every 3 hours. So really important, if you're the team leader, the sister in charge in your general ward, and you have a woman admitted who's breastfeeding but can't have her baby with her, she has to get up every 3 hours to pump. And you need to support that, not like, oh, darling, you know, don't stress, you really need to relax to get better. That's not helpful because this is potentially going to really impact on her ability to continue breastfeeding. And then, apart from, you know, affecting the milk supply, there's also adverse health consequences if she's not emptying her breast properly, because she has an increased risk of mastitis. And this is something really important to discuss with, you know, your surgeons and anaesthetists, because, you know, no good having a successful operation if a couple of days later the woman dies of sepsis because she developed mastitis. So find a fridge for the milk so that she can store her milk and that this can be then fed to the baby who's separated from her. So, summary, even a very brief interruption in breastfeeding can lead to early weaning. Indiscriminate advice to pump and dump is not always in the best interest of the mother and her baby and can potentially cause harm. The breast is not a placenta. Medication safety profile in pregnancy and lactation is not identical. Free and low-cost references for medications that work on smartphones, mobile phones, can be easily and quickly used in most situations. Most common imaging modalities used in ED require no interruption of breastfeeding whatsoever. Anesthesia is almost never a reason to stop breastfeeding. Obtaining a breast pump from maternity or from other services can help preserve a woman's supply while she's in hospital. Thank you for being here and trying to become a better physician to look after your breastfeeding woman.
Thank you very much, Ulrike. Does anyone have any questions? We've got one at the front with your microphone.
Yeah, thank you. This is very useful information. I just wonder, you know, when you ask the mother, encourage mother to pump, would it be like the two breast pumping together is better than just one at a time, one after another?
Yeah, this is an interesting question because in actual fact, it's not. It's just as good to pump one breast after the other. So you don't have to have a double breast pump for effective pumping. The only thing it does, it saves time. Yeah, because if you pump 10 minutes each side, it's 20 minutes. If you pump them together, it's 10 minutes.
Thank you. Thank you. I hope I didn't miss this, but when you were talking about the isotopes and pump and hold for some of those instead of pump and dump, and then you were also saying that they need to be pumping every 2 to 3 hours to match the frequency of the baby that's feeding. when you pump and hold, you still pump and hold every few hours. What do you do with the milk?
You put the milk in the fridge. Obviously, this is milk which contains isotopes, so you have to have the possibility to store that safely. Generally, the women are admitted in a sort of facility where they kind of can't radiate to other people, right? So there are generally the possibilities of having body liquid stored somewhere. So you need to find out. And obviously, if it's not possible, it's not possible. But, I think it's very important to have these discussions with the women. And sometimes just the effort you make to do the best on her, even if you come back to her and say, I'm so sorry, I can't organize it in this way, let's find another way, really shows her that she's being supported.
One final